Today, we are going to do an examination of your ears. Do you feel any pain?
The ear has three components, the external, middle, and the inner ear. The external ear is sometimes called the auricle or pinna. Looking inward, the external ear includes the concha and the ear canal up to the tympanic membrane. The middle ear starts at the tympanic membrane and ends on the bony floor of the middle ear. The inner ear contains the cochlea and the labyrinth.
The concha has the following components: the helix, antihelix, tragus, antitragus, the concha bowl, and lobule. We are checking for any skin lesions like skin cancer and hematoma. Now, we are looking behind the ear in the mastoid area. All looks good.
Common abnormalities of the pinna or external ear include basal cell and squamous cell carcinoma, lap ear in which the antihelical fold is missing and the concha bowl is often enlarged, auricular hematoma in which, if untreated, leads to cauliflower ear. The ear canal has a lateral cartilaginous and medial bony component. The cartilaginous component has the same color skin as the individual. It contains the glands that manufacture cerumen. The bony canal skin is usually pink in color and thinner, therefore sensitive when examined. Common abnormalities include cerumen impaction, otitis externa, osteoma, and exostosis. In usual otoscope to examine ear, pull gently posteriorly on the helix, a maneuver that strains the normally S-shaped canal and allows for better visibility. One should use the largest speculum in which the ear canal can accommodate, as this increases visibility. It is important to remember when inserting speculum, it should stay on the cartilaginous canal. As already mentioned above, the bony canal is quite sensitive. You need to remove any wax out of the way to better visualize the tympanic membrane. The tympanic membrane may be silver or gray in color and translucent to opaque. The most prominent anatomic feature of the tympanic membrane is the handle of the malleus, which sits in the tympanic membrane and is somewhat anterior in position at its distal end. Extending from the distal end of the malleus, also known as the umbo, is the light reflex. This will help orient towards anterior-inferior aspect of the tympanic membrane. It is important to remember that the presence of the light reflex doesn't necessarily mean that it is a normal middle ear. The light reflex is important in evaluating pneumatic otoscopy for the mobility of the tympanic membrane. This needs to be done and documented for every pediatric patient and be accomplished on every adult whenever possible. In the pediatric patient, the tympanic membrane may appear to be normal but have no mobility, suggesting presence of an effusion in the middle ear. Surrounding the edge of the tympanic membrane, one often sees a white structure which is cartilaginous annulus. The tympanic membrane itself is made up of two components: the pars tensa, which makes up about 90% of the tympanic membrane, and the pars flaccida. The pars flaccida sits above a bony prominence known as the short process of the malleus. The pars flaccida may be retracted and be the presenting site of the cholesteatoma. In acute otitis media, the tympanic membrane is erythematous and may be bulging. One tympanic membrane is translucent. One may often view normal structure of the middle ear. Posteriorly and superiorly, part of the incus may be seen, as well as the chorda tympani crossing from posterior to anterior. Posteriorly and inferiorly, one can see the shadow of the round window. Anteriorly and inferiorly, the shadow of the opening of the eustachian tube may be seen. A common middle ear abnormality, especially in the pediatric age group, is an effusion, which may vary in color such as yellow, gray, clear, or blue. At times, one might see air bubbles on air fluid level. The tympanic membrane may have scarring, commonly known as tympanosclerosis, or it may have a perforation. Because the inner ear cannot be seen, a thorough history is extremely important as well as any other additional information that will be gathered. This is true for both neurosensory hearing loss and vertigo. Tuning fork evaluation of the ear may be done but is often of limited value. In the Weber test, the tuning fork is placed on the forehead, the bony nasal dorsum, or the front teeth. Ask the patient to tell you whether they hear the sound louder in one ear or the other.
Do you hear the sound louder in one ear or equal on both ears?
Equal on both ears.
Equal in both ears or they cannot localize the sound at all. Classically, the tuning fork is louder in the better hearing ear in a neurosensory hearing loss, and in the worst ear if there is a conductive hearing loss on that side. The other test is known as the Rene's test, in which the tuning fork is placed on the top of the mastoid tip and then in front of the ear canal.
Do you hear that?
Yes.
How about now?
No.
Louder or softer?
Louder.
Do you hear that?
Yes.
How about now?
No.
Louder or softer?
Louder.
It is important to remember that when putting the tuning fork in front of the ear canal is to put it in either perpendicular or parallel position. A normal response would be that air conduction is greater than bone conduction. If the conductive hearing loss is large enough, then bone conduction will be equal to or greater than air conduction. A normal Rene does not rule out the possibility of a sensorineural hearing loss. When the Rene is normal, it is reported as positive. However, this is rather confusing in that most positives indicate abnormal tests.